Now continue to our final academic session, and please welcome Dr. H.K. Ng to be our chairperson for this session.
It's my great pleasure to introduce my good friend Arie to this session on meningioma. I don't really Arie needs any introduction. I think every pathologist, I mean it, every pathologist has his classic textbook on the brain tumors on his desk. Mine is very wrinkled. The other thing I want to mention about Arie, I think some of us knows that there has been a lot of new information on the meningiomas. It's very difficult to catch up. But the histological criteria that Arie established 25 years ago, maybe, perhaps like that, are the ones we all are still using. So they have withstood the test of time. So that speaks so much for the quality of Arie's work. So you are not hearing my lecture, so you're hearing Arie. So over to Arie. Thank you.
Thank you, HK. Appreciate the kind words. So this is a topic, as you've heard, that is near and dear to my heart. It's really the first major topic that started my career in neuropathology. So I will try to give you a little bit of an overview and an update of where we are now with meningiomas. So let's see, there we go. So no disclosures. I'm a typical pathologist. Drug companies don't really care about me. All right, so this is the data from the Central Brain Tumor Registry of the United States. And what you'll notice is that even though we talk a lot about gliomas and they're very important, the single most common of the CNS tumors is in fact meningiomas, with about 42% of all the reported cases. If you look at the benign tumors, it's an even higher fraction, over half of all the cases. So this is a remarkably common tumor. It seems to have a predilection to some extent for female patients, and every so often, every few years, an actress will have a meningioma, and it brings it to national attention. So all of these are famous people that have had a meningioma. Interestingly, all of them women except for Mark Ruffalo. So normally the ratio is about 2 to 1, and in the spinal cord the ratio could be as high as 10 to 1. Also, meningioma is definitely a tumor of aging, and so as we all get older, the incidence of meningioma goes up quite dramatically. So this is the green line for meningiomas over here. So why study meningiomas? So this has been a tumor that has been fascinating to neurosurgeons since the time of Harvey Cushing, mainly because this is one of the few tumors that, at least in a large subset, they can cure with surgery. Also fascinating to pathologists like Louise Eisenhardt that worked with Harvey Cushing, because there's such a wide range of histologies and clinical behaviors. So as I mentioned, if you're a neurosurgeon, often your perspective is the anatomy. And where is it located? How resectable is it? What are the likelihoods that we can get it all out? And if you're a pathologist, you're looking at these many different types and subtypes of meningiomas. And this is Louise Eisenhardt who was really a remarkable pathologist. She was the first editor of the Journal of Neurosurgery. And if you think neurosurgery is a boys' club today, you can imagine what it was like in the early 20th century. So it's quite a remarkable woman. And this was the first big major breakthrough in the literature for meningiomas, the monograph by Harvey Cushing and Louise Eisenhart. And back then, it was also complicated, even more so than now. So they had 22 major types and subtypes of meningioma. Now, some of these today we know are not even really meningioma. For example, the hemangioblastic type is really what we call nowadays solitary fibrous tumor. But still, it's remarkable the detail that they studied these tumors. So the Bibles of meningiomas, there was one by John Kepish back in 1982, but of course mostly what people follow these days is the WHO. All right, so these are tumors that we've known for over 100 years, or we've thought likely arise from arachnoid cap cells or meningothelial cells, because they look almost identical to the cells we find in meningiomas. And it's basically this dark green layer. And you can notice that it's right underneath the dura, which is probably why most of these tumors end up being dural-based tumors. So like most tumors, we don't really understand the origin or the etiology of most of these. We know that a subset are associated with tumor predisposition syndromes, something my colleague Dr. Pegmeshi talked about earlier in the other room. And the big one is NF2. Now there have been several others that have been identified over the years. And then this is one of the most common tumors that arises after irradiation, whether it's therapeutic irradiation or otherwise. But probably about over 90% of the cases, we don't know what's causing the tumor. All right, so classic patterns that we find for meningioma, these are often very slow-growing tumors attached to the dura. The brain just molds around where the tumor was. In radiology, they often talk about a dural tail sign, which is the fact that the dura does not have a blood-brain barrier. And so meningiomas are homogeneously enhancing, but that contrast enhancement trails out into the adjacent dura. Despite many of these tumors being considered benign or, quote, grade 1, they are or can be highly invasive. When they invade the bone, they often cause this hyperostotic reaction that you can see on X-ray of this resected meningioma. Now, having said that, every one of these is a meningioma. And you can see how remarkably different they look here. So there's a remarkable range of imaging and clinical behavior and histologies. Now, the common type that we've all seen 100 times or 1,000 times is the meningothelial or transitional, where there's whirling tumor cells. Meningothelial cells normally wrap around the brain. They wrap around nerve roots. And so in the tumor, they like to wrap around each other. And they eventually hyalinize and calcify. And you get these concentric layers of calcium that we call psammoma bodies. As you know, they often have these clear holes and or nuclear pseudoinclusions, neither of which is specific but very common. So I won't go through every single subtype of meningioma because there are many, but I will briefly go through some of the ones that cause diagnostic difficulties. One is the angiomatous and or microcystic. They're two different subtypes, but they almost always go together. The microcystic can become macrocystic, and both of these often are described as having more cerebral edema than what you would expect for the size of the tumor. Now, why are these diagnostically challenging? Well, with angiomatous, you get a lot of blood vessels and little compressed tumor cells in between that sometimes are hard to identify as tumor cells. With microcystic, there's a very cobweb-like background and a lot of nuclear degenerative features. And so sometimes I'll get these as consults because they're not sure they're meningioma, or they see nuclear atypia, and the question is this atypical meningioma? So you can get a lot of hyalinization, degenerative atypia, as I mentioned, and can look very funny. With both of these, you tend to get chromosomal gains, especially gains of chromosome 5. Not that it's all that important, but seems to be associated with this subtype. Another one is the secretory meningioma, which is the type that is associated with epithelial metaplasia. So you get these gland-like spaces. This is the most epithelial-like of the meningiomas, with secretions into the gland-like spaces that are eosinophilic and called pseudosomoma bodies. And these are composed of several proteins, including CEA. So sometimes these patients actually have elevated CEA in the blood. But these are highly associated with two mutations, KLF and TRAF7 mutations. And so the subtypes I'm showing so far are almost always grade 1 tumors. So these tumors will show keratin positivity around the gland-like spaces. CEA is often positive in the pseudosomoma bodies. All right. So, more importantly, what can we do as pathologists, and what are the prognostic variables that determine outcome with meningiomas? So, fortunately for surgeons, extent of resection is still a big one, and fortunately for us as pathologists, grade is the biggest one for us. And that is something that I was interested in right when I first started as a neuropathology fellow. More and more, though, the molecular subtype, just like everything else in neuropathology these days, is becoming important. So this is data from the studies that I did with my mentor Bernd Scheitauer back at the Mayo Clinic in the mid to late 90s. And what we found was that the benign or grade 1 meningiomas, that was about maybe 70–80% of cases, they really are benign if you follow them compared to age-matched, sex-matched cohorts. They don't have an excess mortality. So these really seem to be benign. But atypical meningiomas, which are grade 2, have a markedly increased risk of recurrence. Grade 3 anaplastic even more so. And overall survival, there's a slight increased risk of mortality in the grade 2 and a markedly increased risk in grade 3. So the way you can think of it is grade 2, high risk of recurrence, grade 3, high risk of mortality. That's kind of the way we try to define these cases. So as HK was mentioning, the studies we did eventually got adopted by the WHO in terms of grading criteria, and really were there between 2000 and 2021. Still they are there to some extent, but these were the criteria we used for grading for about 20 years. And I'll show some examples of how we do this. And then there are some subtypes, rare subtypes, that are either automatically grade 2 or automatically grade 3. All right, so one of the things that came out early on, and I got complaints from neurosurgeons, right? So before our grading criteria, most of the papers in the old days suggested that grade 2 is about 5% of cases. Now you can see in this study from the UAB in Alabama, they showed all of a sudden the grade 2s went up all the way to 35%, huge increase. And neurosurgeons were telling, what are you doing? I've got to follow these patients. I've got to do more frequent imaging. This is crazy. There's way too many grade 2s. And I lost some sleep and I thought, oh my God, am I overcalling? Are we all overcalling grade 2 meningiomas? So I will tell you that I've had some relief over the years because here are some of the early studies all showing grading is highly predictive of outcome. Here's some more. These, I will tell you, these are all studies that say, well, genetics is better. But if you look at their graphs at just grading by itself, it's not bad. They're doing pretty well. And here's even more recent studies. So I feel finally justified. No, yes, there's always going to be overgrading. But I think there was way more undergrading in the old scheme. Plus, it was so vague. There was little reproducibility among pathologists. So I think it's not a perfect grading scheme. I think it's a good grading scheme. We've done pretty well. We were involved in this clinical trial a number of years ago, and one of the questions we had is, how reproducible is this? So I was the central pathology reviewer, and there were about 60 hospitals all sending cases. And it's not bad. It's certainly much higher concordance than what we typically have seen in the past with gliomas. So I think it's, again, there's some subjectivities in it, but it's pretty good. But we can do better, right? We can do better. So what changed in the last WHO? So one thing is we've always known about NF2. A little over half of cases are driven by NF2, but we now know several other genetic drivers of meningiomas. Many of these are associated with skull base. We know a couple of alterations associated with more aggressive meningiomas, which we'll go into greater detail. We know that there are certain chromosomal losses associated with higher grade. We started to question some of the automatic grade 3s, especially rhabdoid and papillary meningiomas, and I'll show you why. So we don't necessarily automatically go to grade 3 with these anymore, but here is the big change. So one is the brain invasion, which has been controversial for about 100 years almost, and still is controversial, and we basically now suggest if it's an otherwise benign-looking meningioma, don't automatically call it grade 2. That's a change. The bigger change is for the first time we have some molecular criteria for grade 3. So even if it looks grade 2 or in rare cases grade 1, if we have TERT promoter mutation or homozygous CDKN2A deletion, those are automatically now grade 3. So that's the big change. So let's just go back and give some examples of how we grade meningiomas. So some things like sheeting architecture, where you lose that whirling, you lose the fascicle formation, and you just get two-dimensional sheets. That's one of the soft criteria. Or small cell formation, where you have cells with high NC ratios that cluster, or big nucleoli. I consider all of these to be kind of signs of partial loss of differentiation. So these are all soft criteria, along with necrosis, basically, and hypercellularity. If you have at least 3 of those, you can call it an atypical meningioma or grade 2. Now, one of the most reliable features in our study and virtually everyone's study is mitotic count. It's a pain. You got to go to higher magnification looking for those mitoses, but it's highly reliable in predicting recurrence in meningiomas. So here's one with 3 mitoses and 1 high-power field, and notice what's not there, atypia. So atypical does not mean it has cytologic atypia. That is not part of the grading criteria at all. So you can have 0 atypia and it still be an atypical meningioma. It's just not typical. That's basically what this means. Now, there are a couple of rare variants that, as I mentioned, are automatically grade 2. This one is very interesting. It's less than 1% of all cases, but it's very distinctive. Clear cell meningiomas, they have, as the name implies, clear cytoplasm, and a very distinctive block-like or blocky collagen in the interstitium and perivascular spaces that sometimes coalesce into big sclerotic areas. So this meningioma was described in the 90s by Suzanne Zorludomir and my mentor, Dr. Scheitauer. They're more common in young patients. They're often in the posterior fossa and spinal cord, especially down in the cauda equina, and they have a high recurrence rate. So this is why the WHO assigns them grade 2. Now, for many years, we've all said, well, clear cytoplasm is because of glycogen. So I've taught for many, many years, do a PAS with and without diastase, look for glycogen. Well, we finally did a study that we should have done many years ago with one of our fellows, looking at other meningiomas, and about 1/3 of all meningiomas have glycogen. So this is not specific. So despite the fact that it's clear cell because of glycogen, many other meningiomas have glycogen. This is not a reliable way of making the diagnosis. What is reliable? This has a very specific mutation in the SMARCE1 gene, both in sporadic cases, and some of these patients have familial or hereditary forms of clear cell meningioma and have a germline mutation in SMARCE1. So there is an immunostain for that. Very few people have it, unfortunately, but that is a reliable way of looking for the SMARCE1 mutation or loss of the protein. This is a newer study by my colleague Felix Zahm and his group in Heidelberg, Germany. And they are confirming that these should be grade 2. So the overall behavior, this is grade 1 in blue and clear cell meningiomas in black, certainly much worse in terms of recurrence. And compared to other grade 2s, it's very similar. By DNA methylation profiling, they have a distinct cluster, so they seem to be different than all other meningiomas. They're the only meningioma with this mutation, and the biology is distinctive. So this really is a distinctive subtype. The other one that's automatically grade 2 is probably not so distinctive. Chordoid meningioma, as the name implies, looks just like chordoma, except that it's dural-based rather than being in the bone. So this is not a notochordal tumor. It's a meningothelial tumor, but it has this trabecular architecture, vacuolated cytoplasm, mucin-rich stroma, and these also in the original series had high recurrence rates. These tend to be supratentorial tumors. However, by DNA methylation profiling and by next generation sequencing, these are not distinctive tumors. They can cluster with various other meningioma subtypes, some of which are more like grade 1, some of which are more like grade 2. Here is their study. The chordoid is in red. Here's grade 1, here's grade 2. But probably what I would say with these is maybe leave off the grade and do the genetics and see if it's really more like a grade 1 or a grade 2 tumor. So probably the genetics is more specific than the histology with chordoid meningioma. All right. What is brain invasion in a meningioma? It's these little tongue-like or finger-like protrusions into the adjacent CNS tissue. It was defined by Cushing and Eisenhart as meningioma invading past the pia. Sounds great. Not always easy to tell, right? It's very easy when it looks like this. And what I recommend is doing a GFAP. And I kind of draw an imaginary line of where I think the interface is between tumor and brain and look behind that line. If you see little slivers of glial tissue, that's invasive. That's true invasion. So this is obvious invasion, no problem. But in the new scheme, we say if it looks otherwise benign, and I think that's a very rare scenario, but if it's otherwise benign, don't grade it and just wait for the genetics, basically. So here's the original images from Cushing and Eisenhart. So it's beyond the pia. Sometimes it's obvious. Here's the pia and arachnoid, and tumor is mushrooming into the adjacent brain. So going back almost 100 years, good definition. We still define it that way. Now, when I looked at the issue with Dr. Scheitauer and others at Mayo Clinic, again many years ago, we found this to be relatively rare, but was basically associated with grade 2 type behavior if it was otherwise benign or otherwise atypical. More recent studies have not found that and say no, by itself it doesn't predict more aggressive biology. To me, I think it has a lot to do with the definition. So in our series, this was brain invasion was 4% of all cases, and otherwise benign was 1% of all cases, so rare. Some of the recent studies find it in as much as a fourth of or a third of all their cases, which is insane to me. I don't know how you could say that, but that may be part of the reason why there's why there's all this discrepancy. So I wrote this editorial a few years ago, and I tried to show what I consider to be brain invasion, what I don't consider to be brain invasion. So here's an obvious no, right? Nice, broad interface. You can see the pia and arachnoid in between. No brain invasion. Looks great. Obvious, yes. Very clear brain invasion, irregular interface, lots of GFAP in between. And this is a rare case that was otherwise benign and was very progesterone receptor positive. Harder cases. Okay, so here's an irregular interface, and here too, but I still see what I consider to be pia in between. And when you do a GFAP, it looks irregular, but I don't see any of that GFAP slivers in the main tumor. So to me, I say this is no. Many other people would call it, but I would not. I don't think that's brain invasion. Even this, you can say, well, come on, Arie, you're going nuts now. This is not brain invasion. This is perivascular spread along Virchow-Robin spaces. So meninges crawl along the vessels into the adjacent brain. There's a blood vessel in the middle of every one of these areas of invasion. We see this especially in some of the pediatric cases. This is not the same thing as brain invasion. All right, grade 3. How do you make a grade 3 diagnosis on histology? One is anaplasia. Well, that's very subjective. What is anaplasia? Very hard to define, and the best we could do is, I can't really tell this is meningioma anymore. This looks more like a sarcoma or a carcinoma or a melanoma. I can't tell anymore that this is meningioma. That's frank anaplasia, all right? Or a very high proliferation rate. So with atypical, the cutoff is 4 per 10 high power fields, or 1.6 millimeters squared. For grade 3, the cutoff is 20. All right, so 1.6 millimeters squared over 20 mitoses, that's grade 3. And the majority of these will have Ki67 above 20%. The majority of them will have a lot of geographic necrosis. These are all common features. All right, rhabdoid. As you probably know, anytime we see rhabdoid cytology in almost any tumor type, those tumors do poorly. And we found this to be true. John Kepish found this to be true in the same year. We both published our results. And not only high recurrence rates, but high mortality rates. And based on those two studies, the WHO decided way back in 2000, these should be grade 3. All right, so these are defined, rhabdoid used to be defined by EM, but nobody does EM anymore. Rhabdoid means it looks like a rhabdomyoblast, but has no EM features of skeletal muscle differentiation. So now we kind of do it by H&E. We look for these fibrillar or globular eosinophilic inclusions, and that's kind of the poor man's EM. But that doesn't always work. All right, more recent studies found in our original series, most of those cases had other malignant features. More recent studies show, well, if you don't have overtly malignant features, they're not so bad. Survival was 86.7%. So maybe we shouldn't automatically go to grade 3. I think even more importantly, this study by Sandro Santagata at the Brigham found that specifically it was those rhabdoid meningiomas with BAP1 loss or BAP1 inactivation that are really aggressive tumors. And this, similar to the SMARCY1 story, a subset of these are germline BAP1 alterations. And so rhabdoid meningioma is a rare manifestation of the BAP1 syndrome. Other features are mesotheliomas, uveal melanomas, cutaneous melanomas, a variety of features. But this is part of the BAP1 syndrome. So now most of those also have other features of grade 3, but those are probably the ones that are most aggressive. Papillary meningioma has a lot of overlap with rhabdoid meningioma. These are really more pseudopapillary. They kind of fall apart and cling to blood vessels, as you see here. And in the old literature, these also have not only high recurrence rates, but high mortality rates. And so this is why these are called grade 3. But sometimes you see papillary architecture and rhabdoid cytology in the same tumor. So these overlap quite a bit. You can get BAP1 inactivation in papillary meningiomas as well. And more recently, another gene right next to BAP1 on chromosome 3, the PBRM1, seems to be associated with papillary meningiomas. These are probably, again, the aggressive. But similar to the rhabdoid, we don't automatically go to grade 3 anymore. So if you see rhabdoid features and or papillary features, the suggestion I would make is grade it like you normally would. So it might be otherwise grade 1. So meningioma with rhabdoid features, otherwise grade 1, make a comment, maybe do genetics in those cases, and look to see if there's more aggressive features. Now, I mentioned the female predilection, right? So for many decades, people have wondered what is the reason for that. And simplistically, these are progesterone. The majority of the grade 1 meningiomas overexpress progesterone receptor, even though the majority of them are estrogen receptor negative. But there's been many papers about does the hormone replacement therapy or over-the-counter contraceptive pills, does that increase the risk of women getting meningioma? I've even been contacted by lawyers occasionally saying this patient has a meningioma, she wants to sue the pharmaceutical company. What do you think, right? So it's like many things in life, it's more complicated than that. Yes and no, right? So yes, there's some evidence that there's an association, but it's not a huge association. Maybe the risk is close to 2, not a huge risk. But there are these rare cases. For example, we did a study in pregnancy. There are rare meningiomas that take off in pregnancy, especially in the 3rd trimester when progesterone is very elevated. And we wanted to see, well, what do these meningiomas look like? And the interesting thing is some of them, after delivery of the baby, they regress. So it grew like crazy. They're often in the skull base. They cause visual deficits, and they resect these tumors, and then a couple of months later, they regress to a smaller size. So why is that? Well, at least in some of the cases we saw these vascular changes, hemodynamic changes. So hypervascularity in some of these cases, a lot of intracellular edema, extracellular edema. These are probably the reversible changes. It wasn't so much proliferation. So these are not any more proliferative than any other meningioma, at least in the small series that we did. So interesting, right? And the French looked into a larger series of these meningiomas in patients that are on hormone replacement therapy, for example. They found these are, again, mostly skull base, and there are several mutations overrepresented. PIK3CA, TRAF7, these are mostly associated with benign or grade 1 meningiomas. But so yes, there's a hormonal relationship. It's more complicated than just progesterone receptor. There are also androgen receptors, also prolactin receptors. So lots of potential hormonal influences in meningioma. In pediatric cases, NF2, we and others have shown NF2 is, as you would expect, overrepresented because NF2 patients get meningiomas, and they often get them at a younger age. So up to 40% of all pediatric meningiomas, this could be the first sign of NF2. So anytime I have a pediatric meningioma, I suggest germline testing as well, because some of these end up being NF2 patients. A rare tumor type that's overrepresented in pediatrics is the IAP-1 fusions. So we're learning more. So we now know, you can kind of do these Vogelgrams, right, with the genetics. We now know NF2 is not the only driver. There's several others, often associated with grade 1. Grade 1 tumors can progress to grade 2 or grade 3, or you can start with a higher grade meningioma. SMARCA1 associated with clear cell. BAP1 mainly associated with rhabdoid and papillary, but occasionally neither. And those are often grade 3 types behaviors. And then we have these other alterations in blue associated with more aggressive biology. So copy number alterations seem to be very important in meningiomas. We learned about homozygous CDKN2A deletion in several other tumors this morning, including gliomas. In meningiomas, that can occur and most of those have a grade 3 type of behavior, really aggressive, and even if they look lower grade, they behave aggressively. TERT promoter mutation, same thing. So these are rare, both the CDKN2A homozygous deletion and the TERT promoter mutation, but they're very highly associated with very aggressive biology. So this is the reason these two alterations are now considered grade 3 by definition. People have looked at loss of H3K27MA3 as another surrogate marker. These tend to be associated with higher grade, more aggressive meningiomas, but the immunostain can be a little finicky, hard to interpret, and there's not enough data at this point that the WHO has included this in grading of meningiomas. So I mentioned there are often copy number alterations, especially losses of several of these chromosomes, 1p particularly common in the higher grade meningiomas. Now there's been decades of data on this. Here are several papers. I even had a regular karyotyping paper a million years ago in 1996, but several LOH papers showing 1p, 14q, 10, all associated with higher grade. And often we see multiple of these losses. So this is a grade 3 meningioma. NF2 is seen in the majority. CDKN2A homozygous deletion goes with grade 3. Chromosome deletions, 1p and others, highly associated. So this, I think I've got a later slide talking about newer recommendations. It's not in the 6th edition, which we're just starting, but 1p loss will probably be a grade 2 criterion in the next WHO. All right. What about DNA methylation profiling? We've been using that a lot with diagnostics in brain tumors. So indeed, methylation profiling can predict which are the meningiomas that are more aggressive, but there are several different schemes. So Ken Aldapi's group has a 2-tiered scheme with basically favorable and unfavorable. The Heidelberg group has a 6-tiered scheme, although you could argue these 3 are all benign. Maybe these 2 are intermediate or grade 2-like, and this one is grade 3-like. But they also have other alterations that are common. So 1p deletion, CDKN2A, homozygous deletion, TERT promoter mutation. So the question is this independent of other predictors of biology in meningioma? We don't know the answer to that, but there's maybe multiple ways at getting at the same answer. You can do RNA-based techniques as well. So actually, before I get to that, so David Raleigh at UCSF, he has a 3-tiered scheme using DNA methylation profiling and nanostring RNA sequencing as well, also 3-tiered. So there's multiple ways to skin a cat, right? You can get to these answers in different ways. DNA, RNA, copy number, things like that. This one, interestingly, is the only one that's somewhat predictive of response to radiation therapy, but this is not commercially available yet. I think David is working on that. All right, so yeah, so this is the See Impact Now update number 8. This is basically, these are updates that we publish in between the WHOs. So we have less work to do when we finally meet at the WHO meetings. So this is why I say, so these are recommendations for the future molecular grading of meningiomas. So we all felt there's now enough data. If you have a meningioma, even if it looks grade 1, it has 1p and 22q loss, automatically grade 2. So that's probably a future development. When should you consider genetic testing? That's in this block. If you're at a grade 1.5, where it's kind of borderline between grade 1 and 2, it's brain invasive, otherwise benign. I mentioned that earlier. A grade 1 meningioma that recurred rapidly, so it's not behaving like a grade 1. Any grade 2 tumor, these could be more like grade 1 or grade 2 on genetic studies. And any of the higher grade subtypes, the chordoid, clear cell, rhabdoid, or papillary. So that's when you should consider genetic testing. And then you can have, it's not entirely clear, how do we do the methylation profiling? How do we incorporate RNA sequencing? So we've kind of created these somewhat vague classes. So it could be grade 1, but molecularly high risk. Could be grade 2, but molecularly low risk. So we aren't saying just yet automatically downgrade or automatically upgrade, but that's kind of the implication. All right, so we can kind of use integrated histologic genetic diagnoses like we do with gliomas. We're not as far along, but just to give you some ideas, maybe we've got a grade 3 meningioma, it's rhabdoid morphology, it's BAP1 immunonegative, grade 3. Maybe we have a brain invasive, otherwise benign or borderline, grade 1.5 tumor, but it's got 22q and 1p, that's automatically grade 2. Anaplastic with several alterations, grade 3. And still the questions are, again, if it's grade 1, but molecularly has some worrisome features, do we automatically upgrade? Don't know yet. If it's grade 2, but seems to be more benign genetically, should we downgrade? Don't know yet. So these are questions for the future. All right, so coming attractions. We've started the C-Impact Now papers again. We've got 8, 9, 10, and 11 already published. 12 and 13 are in the works right now. We just had our first couple of meetings for the next WHO, and I would say probably 2027 for the next WHO. I doubt we'll get it published within 2026. So that's kind of where we are. This is a big summary. Now, some of you know my main hobby is singing. So I've got on YouTube 14 neuropathology educational songs, and one of them is a meningioma song. It has kind of a Spanish flavor to it, so feel free to look it up if you like, and I will be very happy to take questions at this point. All right, thank you.
Thank you, Arie, for the lovely talk. And I do mean lovely because your
Thank you.
PowerPoints are, some of them are pure artwork. I like the way you, other than the photomicrograph, the way you make the Kaplan-Meier curve comes out. The way you did them is another level. Anyway, a question from the floor, if anyone?
Thank you very much.
Sure.
Incidentally, before I came, I had a meningioma grade 1.5.
Mm-hmm.
And we don't have any in-house molecular testing for neuro-oncology yet. It's in the pipeworks. And the two providers that we have available, I was reviewing their panels, and they've only got, both of them, 1P and no 22Q available for analysis. So what is your advice? What kind of, is there like a surrogate molecular aberration that
The
we can...
1P by FISH, or how are they testing?
NGS.
By NGS? Well, if they're doing NGS and they're getting copy number, they should get all the chromosomes. So you might want to ask them about that. There certainly are many FISH probes on chromosome 22, so I thought you were going to tell me that it was 1P because of 1P19Q testing in oligodendrogliomas. And you certainly can use the 1P FISH on meningiomas as well. But you know, you can easily get 22Q FISH probes as well. But if you're getting copy number by NGS, I'm not sure how they're getting 1P but not getting all the other chromosomes. That's a little puzzling to me.
So maybe just ask.
Yeah,
Contact them and
yeah,
ask.
it is an ask. Yeah, yeah. The vast majority of meningiomas with 1P loss also have 22Q, but there are rare exceptions. So, you know, if you're doing just 1P and it's lost, I mean, you're probably pretty safe calling it grade 2, but it's not 100%.
Arie, can I?
Yeah, please.
You have any comment on third mutant only meningioma? You mentioned in the last lecture, you advised us correctly that we have to be very careful of third only glioma. So you have the same, or now no advice?
That's a really good question. The vast majority of the TERT promoter mutant meningiomas are grade 3 or grade 2 by histology. And if it's grade 2, you upgrade. There are rare cases, though, that are grade 1. If it really is TERT promoter by itself, I would use the same advice. I would say be very careful, because the vast majority of them have other high-grade genetic features, including copy number alterations of 1P and other chromosomes. So yeah, it would be rare, but not impossible to get TERT promoter by itself. Have you seen any like that? Yeah, Malike signs out some of our NGS panels. Yeah, the vast majority have other alterations to go with it. Yeah, but it's a good question.
Well, because according to the current classification, it automatically makes them grade 3.
Yes, right. And we went back and backed off from our original with GBM. So, yeah, if it really is by itself, I would maybe back off. But I think it's extremely rare that it would be by itself.
I'm sure in the upcoming classification you will put more
we'll try to figure out, hopefully,
to the world.
Yeah, we'll try to clarify as much as we can. Obviously, you know, you have to have enough literature support before you make changes. So, but yeah, because that would be such a rare scenario. It's hard to point to a paper that says, you know, we had 100 cases. Yeah.
If there's no other questions, thank you very much. We'll release Dr. Perry. Thank you very much for
all right, thank you.
Fantastic lecture.
Appreciate it.
I think this is the last session of the AP-IAP conference. Now, Dr. Perry mentioned about coming attraction. The coming attraction is 2027 AP-IAP Hong Kong. So this is the key coming attraction. For those of you who are in this room, you must have an interest in neuropathology. So I will ensure there's a good component of neuropathology in the program, and perhaps if the advice and assistant of Professor Shanob and Sam. So see you in 2 years' time. Thank you.